I'd like to mention a few more issues, food for thought really on our work together. Three areas: personalized medicine, living evidence and living guidelines, and multiple comparisons. So how to move from NMA to decisions. And I'll show you our new feature on multiple comparisons called Match It. So personalized medicine is central, of course, to everybody's activities, but one should ask according to what? And there are at least three elements that we are working on and that are important. Is personalized according to risk stratification, so patient characteristics in particular, and this refers oftentimes to the baseline risk, age, severity, and comorbidities. And Luba has shown you that MAGIC allows extensive risk stratification, and we've used them, as I'll show you very soon, in large guidelines. There is predicting, sorry for the typo, predicting treatment response, the ultimate goal of precision medicine, which is an extension of all the work done in GRADE and the credibility of subgroup analysis, particularly Eichmann criteria that we factor in and that can modify the relative effects according to specific factors, typically biological or genetic. And so this is also a point of attention when we process the evidence together and try and lead guidance. And finally, you can personalize according to risk or to predicting the treatment response, but the closer to patients is personalized according to the values and preferences. So be able to share the evidence in a way that engages with their own values and preferences and context. So I mentioned risk stratification. I'll point you to one example that I'll let you explore on one of the rapid recommendations on PCSK9 inhibitors and ezetimibe for the reduction of cardiovascular events. We've used this capacity to risk stratify quite extensively. And here you have infographics of how we map risk strata, even up to 8 risk strata for the evidence for a given question. And this led, if you look at all the content MAGIC app summarized here as an infographic, to individualized recommendation according to many of these risk strata, exploring for credible subgroup effects when they are, but also when they aren't in terms of relative effect. So this is an avenue of interest because the more we try to summarize large bodies of evidence, the more we still try to personalize that evidence according to the patient context and the risk strata. I mentioned living evidence and living guidance, where COVID was a breakthrough, clearly, but it started before COVID, as we know, and you know in Cochrane, with thousands of publications daily that we need to process. And now I think the world knows that decision makers need, particularly for specific questions, living evidence synthesis, and I should add living guidance. And we've been part of international networks also through Cochrane on living systematic reviews. We've applied those methods, and I'll point to one example, which is also a rapid rec with the World Health Organization, conducting in collaboration with McMaster University several living systematic reviews, and have done living guidelines according to that. And those are the official living guidelines from WHO on therapeutics and clinical management. In our collaboration with the BMJ, we've also moved further in innovating how to visualize NMAs and networks. As the networks throughout the pandemic included more and more intervention, it became more and more complex and hard to browse. So we had the impediment to push our project and multiple comparisons further, and I'll talk to that. Others have also used MAGIC, so it's not, as I said, MAGIC is at the service of other groups that would like to use those approaches and our platform. And for example, the National COVID-19 Clinical Evidence Task Force in Australia has published a lot of their updates published in MAGIC, and they've demonstrated how they've been able to accelerate the evidence synthesis and dissemination also using our tools. Other partners in COVID and NICE have attempted to use also similar data like us. A few thoughts that I'm just mentioning, but that will deserve full presentation in themselves, is the versioning. And people working in living evidence and guidelines knows that it becomes a mapping of all the versions you have of PICOs, of summary of findings, and of recommendations as well. And in MAGIC, we've pushed this a little bit further in conceptualizing versions according to language, and those are translations, working on translation functionalities across guidelines. Updating is a version across time. Adapting is another version of a same guideline, but adapted in different contexts in countries and jurisdiction. And living is a combination of all of that, particularly constant updating. And so the version control in MAGIC allows you to have access to all tagged modified content, whether that is for language, modification, adaptation, or in the context of living guideline. And there's, of course, a lot of research that we need to do together in the method of living guidance. On multiple comparisons, I mentioned COVID, but there's many other challenges. If you think of diabetes, we've worked on a very large systematic review with colleagues here at MAGIC China, in particular in Australia, combining more than 800 clinical trials, 500,000 of patients in all the anti-diabetic treatments. This is currently being updated as we speak and becoming a living guideline in the rapid rec methodology. And you typically have those tables in the publication that attempt to show the outcomes of interest here on the top on the columns according to the interventions. And already through guidance from GRADE and others on color coding on how to show which might be more beneficial and or more certain in terms of effect estimates. But this is not enough. This is a way to present the evidence in almost a static version in a publication.